So, good afternoon. So, today we will do on case-based discussion on purpura, hemophilia and DIC. So, can anyone tell me what is DIC, the full form? DIC, it stands for Disseminated Intravascular Coagulation, okay? So, this purpura, hemophilia and DIC, these three things are basically bleeding disorders, okay? So bleeding disorders, they are classified into two categories, okay? So, they might be inherited and acquired. Inherited means they are present from birth, okay? Genetic, okay? Come. So, we can classify to another way. It might be because of the problem underlying in the platelets, okay? Then coagulation disorder or in the blood vessel itself, okay? So, inherited disorders, they are genetic, okay? So, the acquired, they develop after birth, okay? Due to various factors like diseases or medication. Platelet disorders, then coagulation disorder or defective coagulation mechanism or vascular disorder. So, today our topic is case-based discussion, okay? But we will be just briefly, we will be saying something so that you will have idea while you are discussing on case-based discussion, okay? So, these things also will be covered in theory class. So, I won't be going to much of detail of this, okay? So that you have a brief idea, then we can discuss the cases later on, okay? So, this platelet disorder, this is because of deficiency of blood platelets. This is thrombocytopenic purpura, okay? Then essential, or this is the types of purpura, okay? Idiopathic thrombocytopenic purpura, then secondary thrombocytopenic purpura, then coagulation disorder. This is because of deficiency of clotting factors, okay? So, how many clotting factors are there? 13, okay? There are some others also like kallikrein, P kallikrein and all those, okay? And then vitamin K deficiency, then anticoagulant disorder, okay? So, we will be discussing today DIC, purpura and hemophilia, okay? Then vascular disorder due to infection or bacteria or and their toxins, then due to deficiency of vitamin like vitamin C. You have heard about scurvy, right? Scurvy, okay? So, then allergic purpura or connective tissue diseases, okay? So, what is hemophilia, okay? So, this is a genetic disorder, okay? Sex-linked bleeding disorder. So, this is abnormality is located on sex chromosome X, okay? And 85% of cases, it is because of deficiency of factor VIII, okay? This is also called hemophilia A or classic hemophilia. So, this is because of factor VIII. We have another type of hemophilia, that is hemophilia type B. So, that is because of clotting factor deficiency of factor IX, remember, okay? That is also called Christmas factor, okay? And they are saying, so what is the clinical history? Patient will give you, there will be episodes of heavy bleeding, okay? Or there will be history of repeated blood transfusion, okay? And how you diagnose is, you have to take very detailed history, you have to ask, okay? And by the laboratory parameters you will discuss. So, can you see this chart here? So, this is the mother and father. Mother, we know like in chromosome the female has XX, right? And the father has X and Y. So, in this disease actually the mother, that is female, they are the carriers. You can see the black, dark black one. This indicates they are carriers, okay? And the father is healthy. So, in their offspring there is, so if you see here, so if they have offsprings, so there is a possibility that 50% chance if the baby is a girl or a son, okay? So, there is a 50-50 chance that one will be healthy and another, the lady will be the carrier, the female child will be the carrier, okay? And this one, the male child will be defective, okay? So, in this disease, the typical history is females are the carriers, but the males, they are the infected or affected one, okay? They will show the signs and symptoms, okay? So, this is, now we will talk about purpura, okay? So, this is characterized by abnormal bleeding due to disorder of platelet or vessel wall. So, what is thrombocytopenia? What is thrombocytopenia? So, platelets are also called thrombocytes, okay? So, if their count is decreased, we call thrombocytopenia, okay? So, in this disease, there will be decreased number of platelets, okay, and or maybe qualitatively defective. So what do you mean by qualitatively defective? One is quantity, another one is quality. So quantity means number and quality the features, the morphology, okay. So it might be the number might decrease or the pathology is itself in the platelet itself. Maybe the membrane might be defective or there may be something lacking inside the platelet, the chemicals and all, okay. So this is another, see, in platelets we have VWF, this is von Willebrand factor, okay. So this is a heterogeneous plasma protein. It has these two functions. So what it does? It facilitates platelet adhesion to the injured vascular endothelium. So basically they helps in the clotting mechanism. So in theory we will learn more about how clotting mechanism happens, okay. So I won't be going much of a detail. This is just a brief idea, okay. So the types are, we call it ITP, okay, Idiopathic Thrombocytopenic Purpura, okay. So characterized by thrombocytopenia, platelet count will decrease here, okay, or due to the formation of antibody against platelets. So the antibody, they will destroy the platelets, okay. There will be formation of antibodies, okay. So it might be two types, childhood ITP and adult ITP, okay. Childhood, so it is seen in the babies and it will resolve spontaneously within 6 months, okay. Just note down the key points, okay. And adult ITP, this is less common and predominantly occurs in females, and the clinical features is usually occurs spontaneously, and skin is the common site where you will see hemorrhages, okay, petechia or ecchymosis, and bleeding occurs from the nose or from the gums, okay. The patient will give you history, okay, and it is based diagnosis by demonstrating thrombocytopenia, then anemia, then antiplatelet antibodies in the patient, okay. So if you do a bone marrow smear, you will see there is increased number of megakaryocytes. So what are these megakaryocytes? Anyone knows? Yeah, those are the from where the platelets will develop, okay. So those will be there in the marrow sphere. So from megakaryocytes there will be so many fragments. So from there the platelets will develop, okay. Can anyone see what is difference? Can anyone tell me what is the difference in these three pictures? What is the basic difference here? So this one is petechia. Yes, tell.
That one is a bruise.
Bruise, or we call it ecchymosis, okay. So what is the basic difference here? Size, okay, size. So petechia are very small, 1 to 2 millimeter, then purpura is more than or equal to 3 millimeter, and ecchymosis, they are much larger, okay. So 1 to 2 centimeter in size, okay. So now we'll discuss about DIC, okay. So what is the other two things what you've discussed, that hemophilia and purpura, okay. Those two words, the bleeding or the ecchymosis, were present in the skin, like in small areas. But here what happens, it is present in widespread or a wide surface area of our body. That means the whole clotting mechanism of our body is affected here, okay. So this will give rise to this DIC. So it is due to the result of large amount of traumatized or dying tissue in the body, okay, which releases great quantities of tissue factor into the blood. So there will be so much of tissue factor. So DIC is basically means like in our body when there is bleeding, okay. So anti-clotting mechanism will try to stop the bleeding. But in DIC what happens, there is procoagulants which will activate. So it will prevent the clotting mechanism. So there will be continuous bleeding in our body, okay. This occurs patient with widespread, if there is so much of septicemia in the patient, so the patient might develop, okay, this clotting mechanism, DIC patient will develop, okay. So there is plugging, there is small blood vessels in the capillaries. We have small those were microvascular system we call it, right. So there will be decreased oxygen and nutrients, so there will be circulatory shock. If there is decreased oxygen in the body, so we call it the patient develops shock, right. There is decreased nutrients will reach to the tissues. So the reason is that so many of the clotting factors are removed by widespread clotting. So this is your case number 1. This one, can you read out? You tell.
A 7-year-old boy is brought to the emergency department with severe pain and swelling of the right knee for 12 hours. There is no history of trauma. His mother reports he has had multiple episodes of easy moving since early childhood. She also notes that her younger son has similar symptoms, but her daughter is normal. The boy has never had significant bleeding after minor cuts, but he developed prolonged bleeding after a tooth extraction last year. On examination, warm, swollen, tender knee with limited range of motion. No
Petechia.
petechiae or purpura.
Then the lab reports CBC is normal here. Then PT is prothrombin time also normal. Then aPTT is activated partial thromboplastin in time. Okay, that is prolonged. Okay, and then bleeding time is normal. So after what I have discussed, hemophilia, purpura, and DIC. So after seeing the history, what comes to your mind? What it might be? Hemophilia. So why you are saying hemophilia? Hmm. Hmm. And that is family history, and then there is history of bleeding. Okay, and this one CBC is normal, platelet, this one aPTT is prolonged. So this is the key points here. Okay, and there is this one warm, swollen, tender knee with I will show you this one. So what is the most likely diagnosis? You just said hemophilia. Okay, it might be hemophilia type A or type B. Okay, so we will confirm that one by lab test. Okay, so what additional lab tests would you do? Will do. What else will do? Will do clotting factor 8 or 9. We'll try to find out their concentration in our blood, in the blood. Okay, and then the pathophysiology. Okay, see here. So it might be hemophilia A or B. Okay, the supporting your this one is male child, then family history, then deep tissue bleeding. Okay, then normal PT, prolonged aPTT, then platelets are normal and bleeding time also normal. Okay, so the additional test you will do factor 8 level and factor 9 level. You will try to find out. Okay, so and then this is the X-linked. What is the this one? Pathophysiology X-linked disorder, and then deficiency of factor 8 or factor B. Okay, they here the intrinsic pathway is defective. Okay, so because of that, you know, in clotting mechanism, how many pathways are there? Two pathways. What are those? And extrinsic. Okay. So here the intrinsic pathway is defective. Okay, so this will lead to prolonged aPTT. Okay, and then this is hemarthrosis. In the history there was warm, swollen knee, right? So we call it hemarthrosis. So it can be seen in the joints. Okay, bigger joints like knee joint, then ankle, then elbows. Okay, so there is deep muscle hematomas because of there is bleeding. Okay, so because of they will accumulate, so there will be hematoma. Okay, so there is no petechia and mucosal bleeding, and management part is not so important for you, but if you are interested you can just read. Okay, so this is case number 2. So yes, can you read out?
A 22-year-old male college student presents to the emergency department with severe lower abdominal and leg pain after lifting a heavy box at work. He denies trauma. The pain is constant and has progressively worsened over 6 months. He includes a history of bleeding problems in childhood, but has not been on regular treatment. He had an episode of prolonged bleeding after an appendectomy at the age of 16. His mother abandoned her uncle and blood disorders. Vitals, BP.
Okay, so these are the vitals. Okay, BP is normal here, heart rate also okay, temperature also, body temperature is okay. Okay, that means no fever. Okay, and then the examination, there is tenderness in the lower abdomen, then flank ecchymosis is there. Where is the flank located? Which side is the flank? Flank here, na, the back side, this side where our kidneys are there. Okay, then no petechia or purpura, no joint swelling. Then in ultrasound they have found out that there is a large right iliopsoas hematoma. So after seeing this, what comes to your mind? What it might be? See the history and see this one. I'll show the lab reports also. Okay, lab reports are not there. Okay, so from the history, what comes to your mind? See, this is a male, 22-year male. Okay, and then lower abdominal pain, and then history of appendectomy at 6, and there is history of prolonged bleeding. Okay, so that is also hemophilia. Okay, hemophilia. So what is the most likely diagnosis? Then what further tests are needed to confirm? Okay, then discuss the pathophysiology. Okay, then what is the clinical significance of an ileoceous hematoma? Okay, so this is again hemophilia type A or B, it might be. Okay, so these are the clues which says us that it might be a case of hemophilia. Okay, so there is factor 8 level deficiency. Okay, then factor 9 is hemophilia B if there is deficiency of factor 9. Okay, and then this is X-linked recessive deficiency of factor 8 or 9. There is same thing, intrinsic coagulation pathway is defective here. Okay, then this part is not so important for you. So case number 3. Yes, you. Can you read out this one? Yes.
A 16-year-old girl presents to the clinic with a fatal osteo small red spots on her leg and arms. The lesions do not black or on reddish. She reports mild fatigue and recent viral illness on 1 week earlier. She denies trauma, easy bruising in the past or any use, no joint pain, abdominal pain or fever. Physical examination, numerous non-blanking ataxia and purpura on lower limbs, now
Lymphadenopathy or hepatosplenomegaly. Vitals are stable. Then so hemoglobin normal, WBC count normal, but see here the platelet count is how much? 18,000. How much is the normal platelet count? Normal platelet count? How much? 1.5 to 4 lakhs per cubic millimeter of blood. So here you can see this very much decrease. Okay, so this is the case of thrombocytopenia, right? So what is critical count? Anyone knows? So it might be asked in your viva. Okay, what is critical count? Critical count. So that is also related to platelet. Okay, so if the platelet count is less than 50, and even some book says if less than 40, okay, 40,000, so that is critical count. Okay, so this one they are mentioning that there is no hepatosplenomegaly. So why you have to take the history or you have to examine for hepatosplenomegaly? Hepatosplenomegaly, why it is important? Hepatosplenomegaly. So the pathology is in the platelets, right? So hepatosplenomegaly. So what happens if RBCs are destroying? Spleen will enlarge, right? So there is no hepatosplenomegaly. That means there is no destruction to the RBCs. Okay. So this is also case of what? This is purpura. Okay. So there is specific type of purpura. So that is your homework to find out what type of purpura it is. Okay. So this is your homework. Okay, this case, this one. So you can this one note down the key points and then you note down the questions. So that will be your homework. Okay. You can click, one of you can click and can circulate in your group now. Okay. So this is another case. Okay. So yes, you in the corner. Can you read out this one?
An 19-year-old college student presents with a 1-week history of reddish purple spots on her legs, especially around the ankles. She reports painful lesions that appeared after a sore 10 days. She also complains of abdominal pain and joint pain in both legs for the past 2 days. Physical examination. Numerous palpable lesions on lower limbs, mild swelling of knees, no mucosal bleeding, vital stable, no
Splenomegaly.
Laboratory tests. CBC platelets 250,000 milliliters normal, aPTT normal, bleeding time normal, TSR elevated, urinalysis,
Proteinuria and hematuria. Okay. And then sore throat 10 days ago. then abdominal pain and joint pain, okay. And there is purpuric lesions, then palpable lesion on lower limbs, and then here see the platelet count is normal here. So this is also one type of purpura. We call it Henoch-Schönlein Purpura, okay. So you will learn more when you come to final year, okay, about that type. But if you mention purpura also, that is fine, okay. So the key points is here the platelet count is normal, okay, the ESR is elevated. So if the ESR is elevated, what does it mean? There is some kind of infection going on, okay. And then urine analysis, proteinuria. What is proteinuria? Protein in the urine, okay. Then hematuria, blood in the urine, okay. Okay, so this is another case. Can you read out?
A 32-year-old woman is brought to the emergency department with severe abdominal pain, vaginal bleeding, and hypotension. She is 36 weeks pregnant and was diagnosed with
Abruptio placentae 2 hours earlier.
Arrival in BP was 80 by 50 mmHg, NR was 128 per minute, RR was 28 per minute, O2 saturation was 92%. She is pale, sweaty, and confused. Physical exam, profuse vaginal bleeding, oozing from 4
IV cannula, that is IV cannula.
extensive
Ecchymosis.
ecchymosis on arms and abdomen, uterus tender, fetal heart sounds absent.
Okay. So what are the key points here? If you see from the other cases and if you see here, what are the differences? So BP, here it is hypotension, right? BP is this one less, okay. Then heart rate, there is tachycardia, okay. Respiratory rate also increase, then oxygen saturation also less, okay. So and they are giving history that there is severe abdominal pain and then vaginal bleeding and then hypotension, okay. And the patient is pregnant 36 weeks and diagnosed with abruptio placentae. So that also like you learn more when you go to gynae, okay. So there is a condition where there is excessive vaginal bleeding. This pathology lies in the placenta, defective placenta, okay. So BP is very low here and then there is bleeding from the IV sites where the nurse trying to put the IV cannula, from there also bleeding, okay. Then extensive, this is a case of DIC, okay. So there is bleeding, you're saying. So what does it mean? That there is extensive bleeding, okay. There is so much that bleeding is not stopping. So it might be a case of DIC, okay. Disseminated Intravascular Coagulation. So it is from the history and all we can understand that it is involving the wide range. It is present all over the body, okay. So these are the laboratory findings. So platelet count again decrease here, okay. Then PT prothrombin time prolonged, then aPTT prolonged, then fibrinogen is low, then D dimer is elevated, and peripheral spear you will see schistocytes. So this one, what fibrinogen does? Fibrinogen clotting, okay. So in this patient it is level is low, so the clotting it will prolong, it won't stop, okay. And then D dimer also it is helps in the clotting mechanism, okay. So it is elevated here. And then peripheral spear, that is schistocytes. So if you see, these are the normal RBCs, right, and schistocytes are this where the arrow is there, okay. So if you can see here, the shape is distorted, okay. So if you do a peripheral smear, you will see schistocytes, okay. Those are called schistocytes. So this is a case of DIC, okay. So what is the underlying pathology, and then why this abruptio placenta lead to DIC, why are PT and aPTT is prolonged in DIC. So you can answer, right? If you study the platelet part and what I have explained before, so you will be able to answer, right? So this is another case. Yes, you latecomer.
67-year-old
Bit louder.
A 67-year-old man is admitted to the ICU with hypotension and sepsis. He has a history of diabetes and chronic kidney disease. He was found confused at one temperature of 40 degrees. Moved to the hospital. In the ER, immediately interrogated. Examination, he was 70 to 40 kg. Heart rate was 130 and RR was.
Respiratory rate was 32. Okay, then oxygen saturation was 88% and temperature is 40.2 degree centigrade. So this one, what are the points here? BP is low again, and then heart rate increase, respiratory rate also increase, then oxygen saturation decrease. Okay, and then temperature, what does it mean? 40 is more than our normal body temperature. So if the temperature is 40, it indicates the patient has fever, right? High fever. And general examination, the patient is confused, drowsy, then cool extremities, then petechia on arms and trunks, then oozing from venipuncture side. So patient is having hypotension, okay, then high temperature, and then patient has the history of diabetes as well as chronic kidney disease. So it indicates the patient has developed septicemia, right? Do you agree with me? After seeing the history, patient has diabetes and temperature is 40, fever is a case of infection, inflammation, okay. So the patient has developed septicemia, high fever, then altered mental status, okay, shortness of breath, and then other findings like after doing clinical examination, there is crackles in both lungs, okay, then there is core shock is there, then in Foley's catheter there is dark color urine, that is hematuria is there, okay, and then urine output is decreased, okay. So this is also a case of DIC, okay. So these are the laboratory findings. So from the history, if you know, you can diagnose, you can have an idea what it might be, and then you can confirm after doing some laboratory investigation, okay. So here the WBC count is 22,000. How much is the normal WBC count? 4,500 to 11,000, okay. So this is very much increase here, WBC. So in which condition WBC count increase? In case of infection, okay, septic condition and all, it will increase. And then platelet decrease again, okay. Then PT, prothrombin time prolonged, then aPTT is prolonged, fibrinogen is low, D-dimer is elevated, and then blood culture we can see gram negative rods, gram negative bacilli, okay. Then creatinine is elevated, and in smear you see schistocytes are present. So it is like similar to the history of the last case, okay. So only thing is it's a case of DIC which develops because of septicemia, okay. So this is sepsis induced disseminated intravascular coagulation, okay. So these are the clues which will tell you this is case of DIC. There is infection, then hypotension, then multi-organ dysfunction, thrombocytopenia, okay, then prolonged PT and aPTT, low fibrinogen, then bleeding, and then there is microvascular thrombosis. Okay, what do you mean by macrovascular and microvascular? Macrovascular, macro means bigger vessels, okay. Micro is smaller like capillaries and all, okay. Okay, so what is the pathophysiological mechanism? So because of the high there is gram negative bacteria, okay. So gram negative bacteria, they have cell wall, right. So in the cell wall they will release some toxins, endotoxin will release from there, okay. So it will lead to, they will expression on the monocytes and endothelial cell. So this will activate the coagulation pathway, okay. Then other things are cytokine storm. What are the cytokines? You have studied in blood, right? Blood and immunity. There are so many types of cytokines are there, okay. So they are also elevated in cases of inflammation or infections, okay. So and then there is fibrin deposition, okay. Then consumption of platelet and coagulation factor. This is the like pathology why bleeding develops, okay. These are the causes, okay. So why does the patient have petechiae and bleeding from the IV sites? Because the platelets and coagulation factors are consumed faster, they can be replaced, okay. So the platelets and coagulation factors, they are consumed faster, because of this the bleeding mechanism is not stopped, okay. So for normal bleeding to stop, we need these coagulation factors, okay, and then platelets, okay. And because of platelet deficiency, there is petechiae, and then coagulation factor depletion, because of that there is oozing and uncontrolled bleeding. Then fibrinogen depletion will lead to inability to form a stable clot, okay. So can anyone tell me, after suppose you have a cut injury, okay, so what is the first mechanism that happens to stop the bleeding? What is the first mechanism after you get a cut injury? Platelet started? No, that will come later. What is the first step? First there will be vasoconstriction, okay? Because the endothelial smooth muscle is there, no? They will vasoconstrict first. That is the first step. After that, the platelet adhesion, aggregation, all these things will start. So you have to know detail about the, in your viva or in your exam, they might ask you, okay? So why this PT and aPTT is prolonged? Because there is increased consumption of this factor that you have told previously also. There are two pathways, extrinsic and intrinsic pathways, right? So this extrinsic pathway, these are the factors involved, so which will cause the increased prothrombin time, and for intrinsic, these are the factors involved which will cause increase in aPTT, okay. So because of this, okay, the bleeding time is prolonged, okay, because of these two pathways are involved, okay. So okay, before I go to this, so what are the three things we have discussed today? What are the three things we have discussed today? Hemophilia, purpura, DIC, okay. So if in your exam, if any MCQs or if any short note is asked, you will be able to answer, right? Okay. So this is just a brief, but in theory you have to read in detail, okay. Okay, so yes, you, what is hemophilia?
Hemophilia is a sexual disease,
Hmm.
and 85% of the cases, it occurs due to the deficiency of the
Factor 8. Hmm.
so that one is called as hemophilia A or classic hemophilia.
Hmm.
And it mostly occurs in males, because in females, because like females have two X chromosomes, that's why sometimes they can call it as a carrier also. But in males, it is present.
Okay, so in hemophilia, what are the lab findings you will get?
Prolonged bleeding
Hmm.
and
Bleeding time, not bleeding, the clotting time will be prolonged, okay. And what about the platelet count? Hemophilia, platelet count will be normal, okay, because hemophilia is related to your clotting factors, right? So in that case, clotting factor deficiency will be there, okay. So you know hemophilia type A or type B. So if in exam, if short note asks, you can answer, right? Okay. Okay. Hmm. Yeah, yes, you. What's her name? Okay. Can you tell me about Purpura?
And purpura, purely thrombocytopenia,
Mm-hmm.
that means the platelet count will decrease,
Mm.
or like the thing, it will be qualitatively
Mm.
decreased.
Qualitative or quantitative? Okay.
Yeah. And then there are types also, like ITP is there,
Mm.
which is
Idiopathic.
thrombocytopenia purpura,
Mm.
which is seen in adults,
Mm.
where skin is the site for hemorrhage.
So patient will give you history of petechiae will be there. Even suppose there was one term, this one non-blanching. What do you mean by non-blanching? Suppose there is if the hematoma is in your blood vessel, if you press the red color will disappear. Non-blanching means after pressing also the color doesn't disappear, it still remains red color. So patient will give you history that is like very much suggestive of purpura, okay, there is non-blanching. So after pressing also the color doesn't disappear, so it means that the hematoma are under the under the skin or microvascular capillaries. From there the patient is bleeding. Okay. Yes, you. Can you tell me about DIC? DIC.
Disseminated intravascular coagulation.
Hmm.
It usually happens due to an injury to the kidney and
Not kidney. You are directly jumping to kidney. So what is the basic, like what is the mechanism? Why DIC develops?
like activation of the coagulation.
So that is the coagulation pathway. It might be intrinsic or might be the extrinsic pathway might be involved. Okay. So there are various causes, like it may be because of your infection, septicemia. Okay. Because of all these cases DIC might develop. So in septicemia क्या होगा? Because of the gram negative endotoxins and all. Okay. So they will this one cause defect. There will be clotting. Okay. The bleeding time and aPTT and all this, everything will be prolonged. And another thing is that fibrinogen level, the fibrinogen will be low. Okay. The dimer level is elevated. Okay. And in the peripheral smear you will see schistocytes. Okay. So schistocytes, these are the basically the morphology. The RBC morphologies are the shapes. Okay, the shapes are distorted. There are others also, like acanthocytes is there, then teardrop cell. Those are the RBC's morphology. Then sickle cell also, you know, the RBCs become sickle shaped, no? So those are basically the RBC shapes. Okay, they are distorted. Okay. There are 4 MCQs. Okay, so those are your homework. Okay, so you will be write in a piece of paper and you will submit to me. Okay, by tomorrow or at last by day after. Okay, so you can click or you can just note down. Okay, and you have to write why you are saying. Okay, you have to give the reason why that is your answer. Okay, so this is the first MCQ. Okay, this is the second one. This is the third one. And this is the last one. So you will answer those MCQ in a piece of paper and you will write why you are saying this is your answer also. Okay. Okay, so any questions? Everyone understood? So this was just a brief idea, okay? And it might be come as MCQ. If MCQ comes, then you'll be able to answer, right? Any questions? Okay. So you can go to the lab and wait for your practicals, okay?